Hello, everyone. I'm Allison Bateman. I'm a co-chair of the NYU Grossman School of Medicine Working Group on Compassionate Use and Pre-Approval Access, or as we call it, CUPA. I'm very pleased to be co-moderating the second of the joint CUPA and University of Arizona Health Law and Policy Program webinar series on healthcare and research ethics for COVID-19. Today's topic is taking care of chronic and acute non-COVID patients during the pandemic. Not only is this an important and timely topic in its own right, but it's a particularly fitting topic to address in a webinar honoring the life and legacy of Richard Plotkin, who was a longtime friend of CUPA. In just a minute, you'll hear more about Richard, but first I'd like to have my co-moderator introduce herself. And before that, I'd like to share some housekeeping notes. All participants will be muted for the duration of the webinar. We ask that you please enter your questions for our panelists in the Q&A function. You can find an icon below the video panel on your screen in Zoom that says Q&A. Please click on this icon and you will be able to enter your questions. We'll get to as many as we can during the Q&A portion of the event. Claudia?
Hello, I'm Claudia Hirawat, a member of CUPA and executive chair of VOTS Advisors. I'm an active volunteer in patient advocacy for ERORDIS, the European Organization for Rare Disorders. I have served on the Business Council of the National Hemophilia Foundation and on the board of directors of Parent Project Muscular Dystrophy. I'm also a volunteer EMT in New Jersey and worked through the April COVID-19 spike, treating both COVID and non-COVID patients.
Thank you, Claudia, and thank you for co-moderating this with me. And now I would like to introduce Mary Patricia Keefe, Richard Plotkin's widow, to say a few words about Richard. Pat is the recently retired Vice President of Regulatory and Business Affairs for the Mid-Atlantic region for the Southern Company, an energy company. Pat is also a lawyer, a grandmother, and a child advocate. Pat?
Thanks, Allison. So on behalf of my family and myself, I am so deeply honored to be able to tell you a little bit about Richard Plotkin. Richie was an amazing man, and I say this not just because he was my husband, but he was a great father, the best grandfather, and a highly accomplished lawyer, and as he would like to be remembered, a dedicated friend and effective advocate for the very sick and vulnerable in the pediatric cancer community. Richard graduated from the University of Pennsylvania's Wharton School, where he not only excelled in the academic side of the house, but he was also a varsity lacrosse player as well. He went to Georgetown University's School of Law, and after a Chancery Division clerkship, he joined one of the oldest law firms in New Jersey and became one of the youngest lawyers to be admitted to the partnership. Richard really loved the law. He loved being a lawyer. He loved his firm. He loved his partners. And I think he really loved the fight. Believe it or not, Richard was not a confrontational guy, but the law allowed him to fight within boundaries and rules. He was smart. He was principled. He was tough. He was pit bull tough. He was always prepared, always respectful. And above all else, he was honest. And that is what one of the Supreme Court justices told me when I first met Richard. He was a mentor to me. And this is what he told me about Richard. When our grandson, Max, was the night before his 4th birthday, diagnosed with B-cell lymphoma in the bone at stage 4, Richard was inconsolable. He was angry. He was frustrated, but as so truly was Richard, he took a deep breath and engaged. And it was during this very painful 2-year period that Richard really found his niche in the pediatric cancer world. In 2008, he retired from the practice of law and co-founded the Max Cure Foundation, a 501c3 pediatric cancer foundation, with his family. As the executive vice chair, he immersed himself in the mission and oversaw the day-to-day execution of that mission, which involved funding research, financially assisting low-income and military families, and advocating for children with cancer and their families. He was a tireless advocate for pediatric cancer issues, and over the past several years, he was a major driving force in helping children with cancer. Among his accomplishments, Richard was credited with having single-handedly almost caused the issuance of the federal Drug Administration's first compassionate use waiver for a child with cancer of a combination drug therapy consisting of an experimental drug, which was in phase 2, and 2 other drugs that had already received FDA approval and were in the marketplace. He spoke at Harvard Medical School, Texas A&M Mays Business School, and had been interviewed by a number of national outlets. He was appointed by the NYU Langone Medical Center Bioethics Department as the National Pediatric Cancer Representative for existing federal regulations on experimental drugs for children. He was on a panel at the New York Academy of Science Colloquium and was consulted by Congress on proposed legislation dealing with expanded access and compassionate use. He was credited with playing a major role in the passage of the 2012 Creating Hope Act, which incentivizes pharmaceutical companies to invest in developing drugs for children with rare diseases. And P.S., Max is a handsome, healthy, 17-year-old rising senior who finally got his driver's license last week. He has been in remission with no evidence of disease for 12 and a half years now. Early in 2019, cancer knocked on our door. Richard was diagnosed with acute myeloid leukemia at the end of that January. No one ever puts fair in the same sentence with the word cancer, but this was cruel. Yet Richard faced this test the way he faced every other challenge. 3 days after diagnosis, he was admitted to Memorial Sloan Kettering Cancer Center, ready to declare full-out warfare, take no prisoners, and no looking back. For 2 lawyers to be at a loss for words, we learned a whole new language: TP53 genetic mutations, complex karyotypical, advanced cytogenic sequencing. And at the end of 9 days of testing, we learned that because of his heart condition, Richard would not be a candidate for traditional first-line chemotherapies or a bone or stem cell transplant. But he was accepted into a phase 2 clinical trial and actually felt pretty good at the conclusion of the first cycle. But within a day, there was a clot in the PICC line, which became infected, and the culture showed that he had MRSA staph. And although we were never really quite sure whether it was the investigational drug or the broad spectrum antibiotics that he was placed on, or maybe a combination of both, he went into full stage renal failure. He spent 3 months on dialysis 3 times a week. He was dropped from the clinical trial and hospitalized for, last year it was over 140 days. But just like Richard, he fought and got up every time, regardless of the setbacks. And finally, the kidney function came back, and he was able to go off dialysis. Multiple pneumonias, urinary tract infections, bladder, intestinal infections ultimately would clear. And for a while, the new protocol that he was placed on looked like it might work, but it didn't happen. He passed away on the 4th of September last year with his family beside him. And I only give you the background of his illness because during these past several months, I have shuddered to think of how COVID-19 would have impacted his treatment and his hospitalizations. But if you're ever asked who was Richard Plotkin, you can say he was a brilliant man, a fighter, and a friend to the most vulnerable of children. And he would be so honored to know that this symposium was put in his name.
That was lovely. Thank you so much, Pat. Very moving. I'd like to introduce the first of our panelists. These are going to be abbreviated biographies. Detailed biographies of the panelists will be sent to everyone after the event. Our first panelist is Jonathan Agin, who is the Executive Director of the Max Cure Foundation, as you heard, the national childhood cancer nonprofit where he worked with Richard. Jonathan became involved in childhood cancer community following the diagnosis of his daughter, Alexis, at the age of 2 with the fatal brain cancer known as DIPG. He has since worked tirelessly on behalf of children with cancer and their families. Our next panelist is Pat Furlong, the founding president and CEO of Parent Project Muscular Dystrophy and a member of CUPA. The mother of 2 children with Duchenne muscular dystrophy, Pat founded PPMD in 1994 and with other parents of young men with Duchenne. They work to change the course of the disease and to ultimately find a cure. Allison?
Thank you, Claudia. It's my pleasure to introduce our last 2 panelists. The next person is Dr. Carita Grudson, Assistant Dean for Clinical Sciences, Vice Chair for Research in the Ronald O. Perlman Department of Emergency Medicine, and Professor of Emergency Medicine and Population Health at NYU Grossman School of Medicine. Her program of research focuses on understanding and improving the quality of life for emergency department patients with serious life-limiting illness. And finally, we welcome Dr. Chadi Nabhan, a hematologist and medical oncologist who joined Caris Life Sciences in April 2020 as chair of the Precision Oncology Alliance. In this role, he provides medical and scientific leadership for clinical trials, publications, and data collaborations. I'd like to thank all of our distinguished panelists for joining us today to talk about taking care of chronic and acute non-COVID patients during the pandemic. I encourage listeners to type questions into the Q&A function at the bottom of the video screen in Zoom as we go along, and we will get to them during the Q&A period. For all the well-deserved attention that COVID-19 has received, its arrival on the scene did not erase the many existing causes of illness, suffering, and death that so many patients and caregivers experience. Yet medical care for these last few months has very much not been business as usual. In COVID-19 hotspots, patients have been asked to avoid seeking emergency treatments from hospitals. Ambulatory surgeries have been canceled, which has had significant impacts on hospital centers' finances. Globally, clinical trials for myriad conditions have been slowed or even halted. Pediatric vaccinations and checkups have declined. Some patients have been told that conditions that were essential and urgent to them, for example, infertility treatments, were not actually essential and that they could just wait. Other people have experienced delays in obtaining abortions. And yet at the same time as all of this, transformation of the medical system and delays of care has been happening, there have been some bright spots. The increased ability to access telemedicine has been a boon for some patients, such as those seeking psychiatric counseling, those who live far away from treatment sites, or those for whom in-person visits have had physical challenges. Some clinical trials have made modifications to reduce participants' need to travel at this time, and rules banning the use of telemedicine for substance use treatment have been lifted, which has increased access for what is another epidemic at this point in time, substance use. Claudia?
Yes, the purpose of this panel today, this discussion, is not to point fingers or to lay blame. We want to engage in an open dialogue about what challenges are for providing medical care and clinical research opportunities for patients with chronic and acute conditions other than COVID-19 during this pandemic. We'd like to think about how to balance the ethical concerns arising from trying to balance the needs of all patients, both those with and without COVID-19. Our hope is that by considering the needs and concerns identified by patient advocates and the needs and concerns of clinicians in the same conversation, we can start to think about how to make this difficult situation better. With that backdrop, I'd like to pose the first question to our panel. What has been your biggest concern regarding the impact of COVID-19 on the medical care provided to non-COVID patients, be those chronic or acutely ill patients? And I'd like to start with Jonathan, please.
First and foremost, I wanted to thank everyone for inviting me on to the panel. It's obviously a very special experience to be involved for memorial to Richard, who I worked with through the Max Cure Foundation. It's very difficult to identify really one major concern with respect to the impact of COVID-19 on the pediatric cancer community. This is a community that has children that are immunosuppressed, immunocompromised, often spend long periods of time in the hospital. for the administration of treatment or have to go to clinic for weekly visits, depending on type of cancer, their cycles, are impacted in that fashion. So the stakes are really high for children with cancer and their caregivers. COVID-19 has caused a shift in the way that children with cancer, and more accurately, their parents and caregivers, have had to think about obtaining medical care and the cautions that they take, as well as the cautions being taken by medical providers. One of the biggest concerns that I've had is in relation to the psychosocial impact upon not only the child, but upon the parents and caregivers. When my daughter was diagnosed, there weren't restrictions on who could be at the clinic or who could be at the hospital overnight with their child. Now, one parent is in the hospital at a time or in the clinic. If the child is overnight, only one parent can be there. And that creates a whole host of potential difficulties for the child who's either, expects both parents to be there or expects to not have to choose which parent is going to be at the hospital. The decision as to where to seek treatment for parents and caregivers has been impacted. It used to be that without COVID-19, you could look at clinical trials anywhere and everywhere. Now you have to be a little more concerned about where you're going to seek treatment. If you're talking about seeking treatment in a quote unquote hotspot, Texas particularly, Texas Children's, people are thinking twice about whether or not to enroll on those clinical trials. There's delays in treatment, delays in seeking attention for things that pop up during the course of the administration of treatment. Spiking fevers for kids with cancer is a significant issue depending on the therapies that they're on. And parents are having to make a decision. Do you take your child to an emergency department or do you wait? The entire paradigm has shifted, unfortunately, and there's a lot of small concerns within this bigger concerning umbrella.
Even getting to an emergency department can be very complex right now. Chatty, would you like to add to that? Would you like to go next? Jonathan, while we were waiting to see if Chatty wants to add some of his perspective, do you have any thoughts about, should the family be allowed to make that decision of their desire to stay with the child or not?
It looks like Chatty is on his phone trying to come in. It looks like he's still muted.
Yes, he is.
So yeah, I think that it's a difficult question. So it creates a lot of difficult issues. I think I just heard him.
Chatty, do we have you?
Yeah, can you hear me?
Yes, thank you for dialing in. Appreciate it. Apologies for the technical issues.
I have been dialed in.
Yes, we've seen your face. We couldn't hear you. Apologies. We would love to hear your thoughts if you'd like to add some to this first question.
Yes, thank you. And look, I think a lot of the things that Jonathan highlighted apply also to what I'm going to say. And I agree, it's very difficult to pinpoint only one area of concern. There are several areas of concern, but maybe I'll highlight a couple. Oftentimes in oncology, we are trained that most cancers, early treatment, early identification of disease, and early initiation of therapy is really important to optimize patients' outcomes. And I think with everything going on with COVID-19, many patients were very concerned to even voice some of the symptoms that they may have and to seek medical attention. So there is clear possibility that many patients did have delay in their diagnosis. And I actually predict in the years to come, we may see what we call in oncology, quote unquote, stage migration, where a lot of the patients that have been diagnosed in the COVID era have more advanced stage than patients that were diagnosed in the pre-COVID era. I don't have hard data on that yet, but that's really my prediction. The other thing is that patients who receive treatment with chemotherapy for cancer they could encounter certain complications or symptoms after the chemotherapy that need to be managed appropriately. And I believe there was a lot of fear in voicing some of these issues because many patients may not really want to come to the emergency room. I know of several cases and several scenarios, and a patient that would have significant bleeding, let's say, and instead of going to the emergency room to have the bleeding managed, they really want to just stay home and try to deal with that. And that's really a big issue. But I really want to focus on one psychosocial aspect that Jonathan mentioned about being with your loved one when they are diagnosed with cancer. With any type of disease, this is critical. In pediatric population, even if you have to, whoever it is, you need to have the support from your family. That applies, in my opinion, for all patients across the board, and it's certainly heightened in oncology patients, in patients with cancer. Patients with cancer, when they are diagnosed with life-threatening illness that is threatening their existence, they need the psychosocial support. They need the hand-holding. They need to be able to talk to somebody. And let's face it, FaceTime and just a phone call sometimes just don't do it. I think we're lucky to have that, because if we imagine that this pandemic 20 years ago when we didn't have this technology would be a worse situation, but I think it's really difficult. We want to have the support for patients when they are really hospitalized. So these are some of the items that really concern me, and I think time will tell the impact on cancer care with this pandemic.
That's great, thank you. Switching gears a little bit, I was wondering, Pat, if you could take a stab at that, talking from the Duchenne muscular dystrophy perspective.
COVID-19 has had a considerable impact on rare disease patients, and their concerns really stretch across the trajectory of the illness. Certainly, Jonathan and Chatty have mentioned some of those that pertain in terms of going to the hospital with maybe a single parent or maybe none at all, and certainly the impact about being immune suppressed and highly vulnerable. But for example, in Duchenne muscular dystrophy, the routine healthcare visits were canceled, and so were the clinical trial visits. Families who are anxious to participate in these clinical trials, and often these clinical trials are in a narrow window based on function or age. So they sat and waited as this child may just screen fail because of age. So the gene therapy studies are all 4 to 8 years old. So children whose birthdays are 8 years old during this pandemic are going to be outside the window of those trials. So hope is diminished then, in addition to the fact that if it's a functional outcome, this is a debilitating disease over time where function is lost. So if a trial is ambulatory, for instance, or requires a certain level of respiratory function, they can just time out of the trials based on functional loss over a period of months. So families with young adults and adolescents on whom are on non-invasive ventilation really were isolated in this time. And the thought of taking one of these individuals to an emergency room or to a hospital where they would rely on people who weren't expert in their disease, didn't know how to manage their non-invasive ventilation, may see lower oxygen levels and give them oxygen as an example, which may further depress their respiratory apparatus. So really these are fragile individuals, and their families have been really devastated by COVID, not only in routine visits, the worry about a clinical trial visit that's missing data, maybe delayed approvals, but also the feeling of being isolated alone. And the mental health issues here of this isolation are significant in the population.
Thank you. Corita, would you like to add your thoughts?
Sure. So I spend most of my time doing research on persons with serious illness, but I also practice in the emergency department. And I think the most striking thing to me during the peak in New York City was that almost everyone, we had a COVID team in the ER and we had a non-COVID team. And the non-COVID team, where usually we were seeing over 300 patients a day in each of our EDs, there were no patients on the non-COVID. Like everyone, I would say 95% of people were there for symptoms of coronavirus, which is shocking because where were all the other diseases, the manifestations of those, you know, either acute or chronic illness, like appendicitis in children, you know, patients with, you know, we've talked a lot about patients with cancer, patients, you know, still needed dialysis when they had complications, or, you know, a whole host of things that people should have been coming in for. They clearly were not presenting with, so they were clearly staying home and not getting appropriate care. And it was just heartbreaking. And we've seen a little bit of that come back. And I don't know that we've studied in a rigorous way, but I'm sure that the other panelists are correct that a lot of disease processes are continuing on without proper treatment during this time. And once again, there's no great answer, but I think being adaptable and switching gears quickly to reopen all those services, which is a lot of what we've done at NYU, is so important because, like we said, time is ability, functional status, all the things we talked about. As time goes on and people don't get those services they need, you know, we talk about medical care, but there's also physical therapy, occupational therapy, respiratory therapy, all those things that people with, you know, illness need to keep going. There's, you know, I think that's really frightening. And I think to us in the ER, we just kept having these discussions like, where did appendicitis go? Clearly people are still getting it. So what, and it's a surgical disease. It doesn't go away on its own. And these are a lot of questions that are still unanswered.
Thank you.
So I'd like to use moderator's privilege. And before we go on to the next question, I have a follow-up for Pat, if I may. Pat, I have a question. You mentioned, you know, external, you know, respiratory support for some of the boys with Duchenne. I am aware of other patient communities that, you know, need home oxygen, need home, you know, sort of respiratory support, who were really frightened when we started hearing about shortages of ventilators and feeling concerned that either they would be, you know, deemed not deserving of these now limited supplies, or that if they needed to get a replacement, you know, unit, there just wouldn't be anything out there, and we're really concerned about being at home and running out of oxygen or you know, the other respiratory supports that they needed. Did you encounter this in your community? And if so, how did you address that fear?
So we didn't encounter it here in the United States, but we did encounter it outside, where, so in terms of some insurances, patients who use non-invasive ventilation, there are essentially meters on that non-invasive ventilation that determine whether that individual has used it, in their view, in sufficient quantity of time per day, and made a decision of whether, in fact, the time used in that day meant that, indicated that patient really needed it or not. So in some cases outside the US and Eastern Europe and Western Europe, what we were seeing is those non-invasive ventilation, in our case BiPAP ventilation machines, were confiscated to take into the hospital setting. In Italy, this happened frequently, and the patients were left without their ventilatory support, which is used at night by some arbitrary designation that they didn't use it, they didn't require it in sufficient time for that to be consistent. The patients in general with Duchenne muscular dystrophy are not on supplemental oxygen, but their issue is that laying flat at night as their respiratory apparatus declines, they really can't push out the CO2. So you don't want to give them oxygen because you further impair their ability to blow off that CO2 and you depress their respiratory apparatus. But they also didn't want to take their equipment and go to the emergency department with any kind of risk involved or questions involved, for fear, for this anxiety that they held is, will this ventilator be confiscated for someone else based on a greater need, or based on a determination that a rare progressive debilitating disease isn't. I mean, one of the biggest fears of these families is my son going to be considered salvageable, right? If they're doing a triage about who to save and who not to save, is he going to be in the group that is considered not worth intervening? And so that has been an incredible fear, along with the equipment fear.
Thank you, Pat. That's a really helpful and provocative answer. And I hope we circle back to the idea of, you know, if you go to seek medical care and you have a life-limiting disease, or you have a sort of, you know, troublesome, you know, trajectory ahead of you, do you have to worry about being deemed, you know, not top of the list to triage scarce resources to. But I want to pick up on something else that you said for a moment and ask another question to our panelists. And Karita, just to give you fair warning, I'm going to go to you first on this one. But I just wanted to touch on this idea of fear. So, I mentioned, in hotspots like New York City, where I live, people were told, the health department put out a message that you are not to go to medical centers because we need to leave those resources available for people who have COVID-19. And now that's been reversed. Now they're saying, please, like Karita said, don't stop. We know you're having problems. Go to the emergency room. People are just scared. They're like, will I get infected being in the hospital? I already have this one issue. I don't want to get COVID on top of it. So would you just talk about fear as it relates to access to medical care for patients of all sorts? And Karita, we'll start with you and then go to Pat.
Sure. It's a great point. And I think I was just looking through the chat also, and I think it's so interesting the way that we have sort of prioritized this disease over so many other diseases. And I think it's the first time we've actually said to people, don't come to the emergency department. We've never said that before. It's always, our motto is come everyone, we're here 24/7. And people really listened. I think it's just a very interesting other side topic that, the volumes were pretty much the same at our peak. It was just all coronavirus. And nationally now, we see that the emergency department volumes have dropped by about 50%. Every year they're increasing because it's somewhere that patients without insurance, we have a mandate to take care of everyone regardless of ability to pay, which we're the only, section of healthcare where that is the case. So we provide care, 24/7 to anyone that presents. And so the concern now is that people heeded that warning so much that now that in New York City, at least, there are obviously hotspots all over, but people really are continuing to be afraid, even when there are really great protections in place. In almost every, we know a lot more about COVID than we did 3 months ago. So I think there are a lot of protections in place now in clinics, in hospitals, in emergency departments, in terms of PPE for patients who even don't have symptoms, and for staff, nurses, doctors, all the other folks that work in the hospital. And so I think we got to get the message out that it is safe now, and that if you need that care and you can't get to your doctor, whatever, whoever your specialist or is, it is safe to come in and it is appropriate, absolutely. And I think that messaging needs to get out because clearly people are suffering at home and not getting the care they need.
Thank you. Pat, do you have thoughts on that?
Yeah, I do. So in rare disease, first of all, is a great deal of patients that are pediatric. And if we think about these rare disease patients as an incredibly vulnerable population with life-limiting or certainly life-threatening diseases, and many of them, at least, include functional or cognitive loss or life itself. So this is a protected population by the families who have this diagnosis within. So you get this. One mom described this as a continuous panic attack, right? That every single day she's waiting for the next infection, next shoe to drop, as it were. So they didn't want to go to the emergency room, and they further didn't want to go to the emergency room to be separated in terms of a teenager or young adult, because in general, and by definition, when you have a child with a rare disease, you become their advocate. You become their primary healthcare provider in many ways, because 24/7 you're answering your own healthcare questions about what should you do, how should you manage, what are the accommodations you need to make to go from A to B. So I think that there was and continues this general fear. And I think, Karita, to your point, I think there's this general belief that the physicians and the practice of medicine is safe, but it's the other people that are in this environment that there is a concern about how safe are they, how what are their cleanliness practices? Are they being very careful? Who are they, who are they seeing at home? Who are they exposed to? What are they bringing in? So that fear continues, I think, and there is a real reluctance to go back to an emergency room, or for that matter, to a clinical visit.
And just to use moderator's privilege again, I would say I've actually heard the same thing with patients expressing, or potential patients expressing reluctance to use an ambulance. And Claudia probably has experienced this, but people saying, like, I know that that's a contaminated environment. Why would I possibly get into that? I'm going to get in an Uber and, drag my bleeding self or whatever to an emergency room that way instead of getting in an ambulance. And Claudia, when it's your turn, you can invoke moderator's privilege and address that if you want. But I want to go now to Jonathan. Jonathan, do you want to talk? I know you mentioned fear earlier, but do you want to expand upon your comments?
Yeah, there has been a lot of fear that's been bred by lack of really coherent leadership as an umbrella over this entire pandemic. With respect to the childhood cancer community, thankfully, we have really solid leadership and guidance as created by the Children's Oncology Group, COG. And early on, they put out various guidelines and tried to ease parents and caregivers' fear over going to a clinic, going to the hospital, going to the emergency department. And, it was interesting. I had a webinar early on with a researcher who also is in the clinic as well on the pediatric cancer level. And he himself is a pediatric cancer survivor and has had significant issues as a result of the treatments that he endured when he was 16, 17, 18. He's had some valve replacements. He's got just a whole host of issues, and he hasn't been able to go to the clinic or go to his lab since the pandemic started because he's obviously at a higher risk. But the comment that he made to me was something that eased my fear a little. And I know I heard later on from parents and caregivers who were on the webinar that it eased their fear as well. The pediatric cancer community as a whole has always had to endure fear over having your child infected with something while they're on treatment because of the immunosuppressive nature of a lot of the therapies, and because a lot of them are immune compromised as well. So, what he said is, in a lot of ways, we've already been here. We've been doing a lot of what we've been told to do from day one in terms of making sure that cleanliness is next to godliness, making sure that you are wearing a mask, making sure that you're washing your hands all the time. And so, on the one hand, there is and has been a heightened fear with respect to the need to go to clinic or the hospital or take your child in the middle of the night if they spike a fever to the nearest emergency department. But on the other hand, for the most part, pediatric cancer families are given a lot of really solid information to try and reduce fear overall. And so, it's had a significant impact, but as this researcher said, we have always been in this place. So, it's the double-edged sword for this community.
And I'm really glad you brought that up, Jonathan, because I've actually heard that from other people who have immunosuppression, related issues who say, now the country is experiencing my existence. And because so many more people are experiencing it, my life is actually improved. I can now get my groceries delivered to my door. I can do curbside pickup of all sorts of stuff. I mean, now accommodations are being made for those people who need to, have some sort of distance between themselves and others. Whereas before, I was just completely out of luck and had to depend on either, friends and family providing stuff for me or taking my chances. So, I think what we're trying to do here is to say in many ways, patients have been inconvenienced or actually even hurt by, suddenly this shift to COVID, but there have been a few bright spots. And I think it's important to recognize those as we try to think about how to move forward. But no one wants to hear me. They want to hear Chadi. So Chadi, what do you think?
Let's try this. Hopefully this is better. Now you can hear me. I figured out how to move this. No, look, there are two things I'd like to say. And one, there's rational fear and irrational fear. I think fear is an emotion that we all have experienced, and sometimes it's appropriate. And I think there's sometimes irrational fear where you're afraid of things that you just shouldn't be afraid of. And Jonathan alluded to this a little bit, but I'm not really sure. I think I agree that sometimes the irrational fear would go away if you provide a little bit more of guidelines and guidance. But really, the medical community didn't know what type of guidance to provide, because this was, let's face it, the medical community and all of us were not ready for something like this of that magnitude, and we just didn't know how to handle this. So we just need to realize that sometimes we just don't know, and we're just trying to find our way as more information trickle in. So that's an unfortunate situation, and it's not going to be the last time we deal with something like this, and hopefully we'll be more prepared. But I do think as we improved our knowledge with what's going on, we should have been able to minimize the irrational fear and help patients as they really needed to seek care. And I think from a cancer perspective, the worst thing could happen to an immunocompromised patient who's receiving therapy is if they're home and they spike a fever and they decide not to seek medical care. That could be really the difference between life and death. And we don't really have statistics to be able to really go in and just say, well, we believe that these are the avoidable deaths, for example, that happen for some patients if they've sought care. I believe these will actually come in at some point in the future. But it's certainly top of mind, and I think we have all had scenarios in our own families or friends where we've tried to manage things at home and avoid also medical care when we could. I think right now we're having this conversation in July. We obviously have way more information than February and March, and my concern is that the fear continues after 4 to 5 months, where that's really problematic. So my answer to this long-winded commentary is, I would like us as a community to get together and work into how do we get rid of the irrational fear that has emerged because of everything that happened. Because at the end of the day, in 3 years, when we look back at this, we wouldn't really do well if we realized as a society, we've lost more patients in total from the way we handled the situation than from the pandemic. So I'm very concerned about what's going on, and hopefully hopefully my concerns are just concerns and are not going to be solidified by data.
Thank you. I think I just wanted to add that as an EMT, while I actually have never seen appendicitis, so I don't know what happened to it, but we did see several immunocompromised patients, and they were well-trained and knowledgeable enough to call ahead and let us know that that was the issue. So we went through extra careful measures to prepare the ambulance for their transport, to prepare the entire team so that they would have the absolute best transport. And even through the peak weeks of COVID infection in my area, we transported all patients who we believe needed to be in the emergency department. But we were under orders from the Department of Health to triage to home, which meant that if patients were not an emergency, there were certain guidelines that we were to follow and to advise those patients to stay at home as opposed to come to the emergency department. And I hear a lot of people still referring to those, that they called 911 and they were told to stay at home anyway. And I think that kind of lingers. Those protocols have now changed, and we're bringing in patients. If they want to go to the ER, we bring them in. But certainly that is something that stays because it is an unprecedented experience.
Hey,
and
Claudia,
sure.
before you move forward, sorry, I'm going to put you on the spot. So as an EMT, there was, I believe, a policy floated, I don't know if it was ever implemented, not to do CPR out of the hospital for fear of, sort of aerosolized virus. Can you talk about that?
Right, it's fascinating because it was actually passed through in New York, and then it was taken back because it got so much of a backlash. There were discussions in different areas in New Jersey, but there was no real adoption. And I can tell you, interestingly, that at the squad levels with EMTs and paramedics, I don't think it is something that any of us was prepared to implement. We certainly did a lot to add, HIPAA filters to the bag masks that we use and create all sorts of we were visors and every kind of protection. But I don't think with the training that we have, with the motivation that we have, that we were prepared as a team to really walk away from a situation where CPR was required. But I know there were some areas where that was mandated. That the whole CPR issue is in debate, like the entire validity of it and how efficacious it really is. It is a bigger question, but I think right now we're back to the standard protocols at least. So if we can switch gears a little bit, talking about one of the most heartbreaking parts of medical care in the time of the COVID-19, it has been watching patients lose access due to visitor restrictions to the in-person support that their families or friends could have provided. Some women delivered babies without any companions. Some patients had to go through hospitalization without visitors, even when they were dying. More innovatively, we have seen some children's hospitals offer to house entire families so that they could be with their child receiving inpatient treatment. The closing of national borders and the creation of state quarantine rules have further restricted the number of patients who can have the physical support of families or friends. Pat, can you talk a little bit about how that specifically has impacted the Duchenne muscular dystrophy community, both in regard to medical care and research participation? I know you touched on that a little bit, but if you could just expand your thoughts on that particular restriction.
Sure, Claudia, I'm happy to. In Duchenne muscular dystrophy, one person is typically a primary caregiver for these young individuals, in addition to the fact that they have a lot of aides sometimes coming into the house at different times to provide other services like physical therapy. Because of the trajectory of Duchenne, where individuals, primarily boys, lose skeletal muscle function over the trajectory of the disease, the care needs become extensive, and taking care of all their personal needs, dressing, bathing, feeding, personal needs, to include use of cough assist to help them remove secretions and BiPAP ventilation in the evening. This is overwhelming kinds of care that is required by these young men. The risk of hospital admission without any other individual or with limiting the people that can provide this kind of care is really terrifying to the patients and their families. I think the other thing is research. And in our community, we've heard about the research delays, the lack of the ability to continue research, labs being closed, animal studies stopping. So all of this has impacted our community, and this is the hope that they hold on to. So also we have to think about these families in terms of rare diseases. Most of the time, expert care for rare diseases isn't in your backyard. It's not from your local ER to the local hospital. You're traveling miles to go to an expert care center. So that is by train or by plane or by car. And so there's risk associated, especially by plane, that these parents really cannot accommodate at this time based on state regulations, the exposure risk in a given state. So all of this combined has really changed the way we think and really worried about our hope and our longevity and what happens to these boys at the end of the day. It's been an incredibly difficult process, and I don't disagree with Chatty about the unrealistic fear and the realistic fear, but all of these combined, whether they're realistic or unrealistic, it's really, these families are living in very difficult times, often terrified most of the day about what happens next.
Thank you. Corita, as a clinician, can you add something to how you look at that issue?
Yeah, I mean, it's so vital. I don't know how, I think just need to incorporate a holistic perspective in that way and not, sometimes we get so medicalized that we don't consider all the aspects of illness and the person themselves.
Chatty, did you want to add any thoughts to this question?
Yes, I do. I think it's really fair to say that all communities really have been affected by policies to a certain degree. And I just want us all to be cognizant of the fact that sometimes, unfortunately, these policies are created without so much information that we have, but we just have to have certain policies. And as I said, I believe that having something new that very few people knew enough about is really critical to acknowledge. In early March or the first couple of weeks of March, nobody was talking about universal masking, right? That's really the reality. Now we know we need to do that. I bring this up because policies occasionally have to be stated based on little information, but we also need to be agile. I worry about the fact that today, on July 17, there are still certain policies at major medical centers and institutions that prevent a family member from being with their loved one when they are ill or where they are receiving chemotherapy and so forth. I'll say that if I'm able to go next week and have a haircut with a mask on, I should be able to go to the hospital and visit a loved one who is in distress. So I think that we need to be we need to acknowledge the lack of information and the importance to create policies. And we don't really want to point fingers if a certain policy is wrong or not. No hospital in early March, no hospital had universal masking policy, and it just wasn't there. And in fact, I know of a story of a colleague of mine who was in the hospital wearing a mask where an administrator told him, "Why are you wearing a mask? You're scaring patients and family members." So I think that has changed, right? That has changed. But similar to that being changing, where we are now trying to enforce the proper precautions, we also need to acknowledge the importance of changing certain things that are more patient-oriented, family-oriented. So that is very important. And we seem sometimes not to have the proper balance, and I'm concerned about that.
Very nice. Jonathan, any thoughts?
Yeah, I appreciate everything that Chadi just said because it's so critical for patients, and drilling down to the childhood cancer community with kids who are scared to be in the hospital, kids who are facing so many heavy life questions. It's devastating. Right now, as I'm speaking, friends of mine, they're in a hospital 6 hours away. Their 12-year-old son was just diagnosed with a very rare form of liver cancer that has metastasized. And they chose to treat 6 hours away because the surgical team was willing to go in and try and resect as much as they could. He's likely facing 2 surgeries, and he's likely facing a lot of time in the hospital. Only one parent can be with him at a time. He's used to having both parents around him. He's had to be put on Lexapro to try and take the edge off things. This is a whole new world for all of them. And here they were taking as many precautions as possible to make sure that they weren't putting themselves at risk even before their son was diagnosed. And only one of them can be in the hospital with their son at any given time. So they rotate 24 hours on, 24 hours off. They've gotten them to ease the restrictions a little bit, but again, it's devastating. And something that Pat said in her remarks really has been a significant concern of mine, and that is the issue of research and research continuity. As labs had to shut down, the work was sitting. As staff had to be laid off, as funds dried up, the impact is going to be significant on that front. And the Max Secure Foundation just made a grant to a researcher at his institution to help him put into place some of the precautions that he now has to take to start getting his lab up and running again. And so, it's things like this that are going to continue to have such a reverberation through non-COVID patient populations that, who knows how many years we're going to feel all these.
Thank you. Allison, did you want to move to the next question?
No, I want to put Chadi and Karita on the hot seat because they're the clinicians on this call, and I want to press on this for a second. So I think all of us agree that family support or friend support is not just a nicety, but I mean actually has medical utility and validity. So, normally under all circumstances, you would want that support companion there. You would want the family, you would want whatever. But I'm living in Manhattan where we had overflowing hospitals, where I know we had, say intensive care nursing units who were dealing with not one patient, but multiple patients, not wearing, the normal garb that you would wear in that setting, which is, restrictive enough, but wearing, multiple layers of personal protective equipment when they were lucky enough to be able to get it. It's hot, you can't eat, you're stressed, you're being pulled between multiple patients who are incredibly ill at that moment. Is it really essential to have families put into that environment, or is it more important to say, we're going to do it whatever we can to have you interact virtually with your family, but we cannot have you here right now. We just can't do it. So clinicians, what do you say?
No. Yeah, in April, I agree, Allison. I think you bring up a very good point that, yes, you need to, at the time with what was happening in New York and in April, I fully endorsed that time was okay. I think my concern is that type of strategy or policy continues in many hospitals in July. That's really my concern. It's not, I think back then in April, we all know New York was really suffering a huge disaster, and I presume things are better right now from watching the news about New York. But at least even in the Chicago area where I am, and the Chicago, when you look at the data in Chicago, no state is doing pretty good, but at least reasonably better than other areas. And still on July 17, some of these policies exist. So I fully support what you're saying. I just want us to be a little bit more agile. I think sometimes I feel the policies are too restrictive versus being a little bit agile that looks at what's happening at that particular community and that particular state. So I can tell you with certainty, 100% certainty, that there are several hospitals right now in Chicago that still will not allow visitors on July 17th, and that's concerning.
I would say, I think unfortunately, it wasn't up to me. So it was something that came down from Governor Cuomo. There were no visitors in hospitals. It was a statewide decision. And Shadi just said, I think, in New York in April, when we were overflowing, it was not a safe place for anyone that did not critically have to be caring for the patient to be there. But that was really lack of planning on our part as a nation. We knew this was a possibility, and we could have done a lot more, I think, to prepare. So it was sort of, the worst possible decision had to be made. And patients died alone, which no one should ever have to die alone. And so I think that's just awful. But unfortunately, now in New York, things are so much better. We have, I think, about 100 patients still in the hospital, been there for a very long time. And, patients are now allowed to have one visitor. And that was, once again, a statewide decision based on the evidence and the decreasing caseload, which makes sense. But I think it's not a position we should have ever been in if we had testing earlier on and lockdown earlier on and all of that. So it's just an unfortunate consequence of the way this whole thing was handled.
And so, of course, the reason sort of post-mortem question, like that is to say, how did we handle it? Was it right? Was it wrong? But more importantly, how could we do better going forward? Because we could, who knows, be back in that situation again in some number of months, or if not in New York City, in some other facility, some other geographic area.
Absolutely.
So Jonathan or Pat or really any member of the panel, to what extent are you actually voicing to, if not the governor per se, your institutions or your patient or clinician communities saying, look, we've learned and we don't want to repeat what we did before, so here's how to handle it going forward. Has anyone been involved in conversations like that? I think Pat's talking, but she's
sorry. Yeah, I'm muted. I apologize. Yeah, so we some years back began a program to really identify expert care centers. So these are interdisciplinary care centers with expertise in Duchenne, with a variety of subspecialists relevant to the disease, and they're called CDCCs, or Certified Duchenne Care Centers, and this is by application, review, and site visit, and chart review, et cetera. So once you're designated as a CDCC, then we have this string of about 29 CDCCs in the US, 2 ex-US. So we're talking to these certified centers about what could we do better, what could they do better, and what we're trying to get at is being consistent across. Because I think for patients, one of the most difficult things is to say, my institution does this and allows that and says this, and then another institution has something else to say based on what they're doing. So what we're trying to get at from them by surveys, and we're having every 2 weeks calls with them, hopefully a concrete plan of how to be consistent and what are the things we want to do better, what are the things we want to be aware of, how can we lessen the fear, how can we how can we approach this in a better way? In the same way, we're reaching out through our registry to our patients and asking them about their experiences and for their opinions of what would have helped you be less fearful, be more confident in the care, what makes sense. So we're going to bring that data together and see if we can and think about what to do next, whether that's policy or whatever, how can we disseminate this, at least through the rare disease community.
Now I'm muted. We'll move on to the next question. I just want to say in the interest of putting out policy about how to do this better, I do want to note that the FDA put out policy pretty quickly about how sponsors and trial sites could transform the requirements of trials given the situation so that patients would be required to travel less, et cetera. So I think that was a very responsive model of trying to move forward, and I hope that we see that from other spheres. But let's go to the next question. And so for those of you who don't know me, I am an ethicist, and I am obviously focused on sort of not only the provision of care as a practical and medical matter, but as an ethical matter. So what I wanted to ask our panel is, as was already mentioned, access to medical care in the United States is not a right. And unless you're going to the emergency department, it's not something that you can get, necessarily on demand or, just by virtue of the fact you have a need. There's a social gradient in who can get access to timely, quality medical care, even at the best of times. And then, of course, when you add a pandemic into it, it's not the best of times. So I wanted to ask, from your particular areas of experience and expertise, how have you seen this issue of inequities play out during this time? Are you seeing the same inequities as always persisting? Obviously we're seeing increased inequities in terms of the fact that COVID-19, differentially impacts certain portions of the population. So, that's sort of our backdrop, is that there's been increasing equity. But in your specific areas, are things just the same as normal in terms of inequity of access, or actually is inequity going down because as service provision has slowed or dropped, everyone is being denied access of care, not just some people? So I'm really curious to know how this has worked in your area. And Shadi, I'll ask you to go first if you don't mind.
Yeah, thanks, Allison. This is really such an important question. It's also an important question to my heart because I'm actually, on a personal and research level, very interested in inequities and healthcare disparities. I think it's going to be tough to answer it with real evidence-based manner and data. I think it's a little bit too soon to be able to show charts or graphs today and basically solidify my opinion with actual data. I think next year we'll know more. But so what I'm going to say is just maybe opinion, and you know me, I like to differentiate opinion from actual true hard facts. It's an opinion and based on some of my observations. I know we all know that inequities and disparities do exist in lower socioeconomic status individuals and patients. It just so happens that some racial and ethnic minorities do have the lower socioeconomic status, and that's really why we see some inequities to start with because of seeking medical care. In the COVID-19 era, what we've noticed is, as you know, that the rates of death amongst African Americans and Asian and Hispanic populations was actually higher than Caucasian patients. Whether this is because of lack of ability to seek care, whether because they may have comorbidities that affect the COVID-19, it's really unclear, but there were some obviously disparities in the outcomes based on race and ethnicity, which is really important to understand better over the next couple of years. I will say in the cancer area, the two things that I'm observing is, number one, as I said, the delay in care you will actually definitely see amongst lower socioeconomic status to start with, and that's going to be delayed even further in COVID-19, where there are people who have more access, they'll be able to get some of the care differently than individuals who don't. One area in cancer is screening. As you know, screening is a very hotly debated area, and this is not really the purpose of this panel. So, whether you believe in screening mammography, whether you believe in screening colonoscopy, it's not really the topic of today's panel, but it's absolutely, you're going to see that there's disparity in screening amongst patients who have lower socioeconomic status than those who are not. The underinsured and the minority, they are going to screen even less during the pandemic, and that could actually have an impact on outcomes. It would be actually interesting if we find no differences in outcomes despite lack of screening. It might question screening all over, from the get-go. But unfortunately, in my opinion, Allison, that the pandemic is heightened the disparities more as opposed to flattened it. I think the disparities that we already knew existed in lower socioeconomic status and in certain ethnic and minority groups have been heightened even further during the pandemic as opposed to being flattened. So I saw it getting worse, but I can't show you data to that effect yet.
Yeah, I mean, that answer doesn't surprise me, although it's sad. Jonathan, any comments?
Yeah, the issue within the pediatric cancer community has been access to information for parents and caregivers. And this is such within any rare disease population. Access to information within the childhood cancer community unlocks a world that actually functions at a high level of information distribution to make sure that patients have the ability to seek the proper treatments, and that's because of the Children's Oncology Group, which is a cooperative organization with a vast network of 9,000 plus experts, 200 plus children's hospitals and facilities across the US and internationally that connect with each other. So if a child is diagnosed in X part of the country, they can participate in a COG trial or have access to COG experts at another facility across the country. And pretty soon, as long as they have access to the tools to obtain the information, i.e. computer, internet, and a phone, they can have a better understanding of what they're dealing with. And it's something that the childhood cancer community, I think, does really well. And when it functions at its most basic level, it does it often eliminate some of these disparities. It doesn't always do that, unfortunately, but you know, it's built to do so. You know, there's obviously been greater concern over access to trials and treatments at different institutions due to fears over traveling. But with that said, early on in talking to a number of the folks that are involved in COG and Peter Adamson, the former head of the Children's Oncology Group, you know, there was an effort underway to ensure that there were easing of the restrictions involved with respect to accessing medications and treatments and therapies, consenting on trials, and easing some of the restrictions that you know, I recall from my own daughter's diagnosis and requiring us to travel to different sites to obtain drugs that we could have obtained at home in Washington, D.C. So, you know, again, the main issue has always been who has access to information and how they access the information. And once the child is diagnosed and they have access to that information, they then have access to a network that levels the playing field in a lot of respects.
Thanks for that. Karita, I mean, I know the emergency department is generally like the safety net for all of us, but I'm sure
right.
Thoughts on this.
Yeah, I've just been looking at the data because there's a lot of, obviously a lot of data on disparities and interest from funders and the NIH, especially in looking at testing disparities. And I think it is striking. I've been talking with health systems across the country working on a proposal, and the differences in testing practices vary widely. So there are some emergency departments where, you know, you can test on everyone. There are others, not to be named, where they don't test anyone who's discharged. And this is an area which is quite diverse and disenfranchised in a lot of ways, this region of the country. And so basically what they tell people is you might have coronavirus, but you have to go, we don't do any tests in the ER. You have to go and go to this drive-through. Well, if someone doesn't have a car, they can't go and get tested. So I think there are disparities at every single point of contact with the healthcare system, and in the types of ERs, and for example, like Elmhurst in New York City, which was completely overwhelmed and is known to be in an area where there's a lot of poverty, more diverse racially, ethnically, than other areas where hospitals were more equipped. And I think that's the reality that we face. But there's so many layers of it. You know, we can look at the numbers and say, yes, you know, minorities were more likely to die from COVID. Black and Hispanic persons were 5 times more likely to be diagnosed with COVID. I was just looking at that data today. But, you know, unpacking all the ways in which it plays out from the very beginning, I think is so important, because we don't understand. This has just been writ large on the national stage, but I think just we've got to figure out ways to do better, because luckily this has really been like a call to action across all levels of the health system in terms of just raising awareness about especially racial and ethnic disparities, and just finding ways to decrease those disparities at every single point of contact is so important. I think it's, you know, the imperative of our time in 2020. If we learn anything from this, it's that is just so important to deal with. So, and I heard really good news that they're at our, sorry, you were going to ask a question. Go ahead,
please.
No, that that, you know, there's big change happening. And I think I heard that at some places they're even thinking of getting rid of the wall of white faces in medical schools, that those are going to be dismantled finally. We've been talking about those kind of things for decades. People have been complaining about the white male parade of faces. And I think just all the ways in which we see racism and disparities play out, from everything from whose picture gets on the wall to like who gets a test to who has to still go to work and who gets to work from home. I mean, there are just so many issues, and I don't purport to be any kind of expert on this, but I just think if we learn anything from this, we've got to, like, we can all do our part. So.
And I wanted to ask you a question, which you may well not know, and please say that. I'm not trying to put you on the spot. Mm-hmm. But one of the things that I've been particularly concerned about is anytime you have an infectious disease, particularly one that's easily transmissible, obviously you have to be concerned about congregate populations. And it would have been, you know, very obvious to any, you know, person who understood the epidemiology of this disease, even from the get-go, that the homeless shelters where, you know, large numbers of people are packed in together, or prisons or other such population centers were going to be heavily hit. And so I'm wondering, you know, in my ongoing quest to look and see, you know, have we done anything right? And if so, can we say, you know, let's continue this forward? Did we focus on those centers in a meaningful way from the get-go, in a helpful way, or did we just not? You know?
I would say the real advocates in those areas would say, no, we didn't. I know that, you know, in New York City in particular, there was huge amount of resources put into placing homeless patients who were either patients under investigation for COVID or had a diagnostic test that was positive in hotels, single room occupancy hotels. And there were, you know, huge hotels that were converted basically to places homeless people were housed during COVID. People felt like it didn't happen, you know, advocates, and we have one on our faculty who you probably know, Kelly Duran, you know, did a lot of advocacy at the city level and state level because it took forever to get those people housed. So you'd have them in the ER and you try to get them, you know, a hotel room, and it would take, you know, 12, 24, 36, 48 hours. So was it enough? Of course not. But did people think of it? Yes. And in terms of the prison population, nursing homes, I think most places, most health systems, and most of those facilities are doing a decent job of getting people tested who are symptomatic. Could they do more baseline screening? Of course. Could we do better? Absolutely. Yeah, it's never going to be, I don't want to say it's never going to be enough, but we could always do more. But I think people definitely, right, well, there was like a call to arm. What?
I was just saying, thanks for letting me put you on the spot with that.
Oh yeah, no, you can always put me on the spot. I'm an ER doc. That's what I thrive on, being put on the spot.
Well, you never know. That's why I was thinking about this with regard to you, because you're the one who typically sees patients, right? So,
right.
Matt, any comments on this particular issue on disparities and what we're doing right or wrong as we move forward? I think you're muted, Pat.
Oh, I apologize. So, and I'll just sort of retrench in terms of, I can't comment on testing in the rare disease community because we just don't have any data on it, and it would just be guessing, not even an opinion. But I think what I can say is that overnight, in the rare disease community, we have been begging for telemedicine, to consider lessening the burden on participation in terms of medical care, general office visits, general checkups, as well as lessen the burden on clinical trials. We've been talking about telemedicine, and we saw all these barriers about how do you bill, and from state to state, keeping in mind that parents are traveling hours to get to an expert center. So overnight, with a signature, all of those barriers came down based on this pandemic. And telemedicine is how these patients are being seen now. So that has enabled people who had to make decisions about, so for instance, we did some work in Mississippi and when we were in Mississippi and New Mexico and spoke to some of these families, they would say, we don't go to the clinic because we have to make decisions about food on the table versus gas in the car. So we don't go to the clinic because we have no one to babysit the people that are home, or grandma that we're taking care of, or this extended family that's living with them. So they would make these decisions against achieving that update and that care visit and those questions that they had. So I don't have any data to support this, but we are seeing that families who otherwise had not been to the clinic in 2 or 3 or 4 years for a general check are now being seen through telemedicine. So I don't know if over time we're going to see data that suggests that we are breaking down some of the disparities based on that offering to participate in trials via telemedicine, except for 1 or 2 visits, depending on the study and depending on what the intervention is and how the mode of delivery is of that particular intervention. But I think that the telemedicine, what our real worry is as this pandemic is more controlled, as people are more comfortable, that the walls go back up and they prevent the telemedicine, the crossing state to state, and the willingness of physicians to get in Zoom with these patients, the willingness of interdisciplinary teams to take a look at these patients, the willingness of our academics to look at outcome measures that maybe are video capture or device capture. So we worry that we've enabled an opportunity. We just don't want it to go away.
I think capturing some of these gains, if there are any from the pandemic, would be important. We didn't talk about it today, but it's certainly a topic for another discussion, is the improvement in the availability of mental health services and the ability to treat patients over Zoom and FaceTime, going over restrictions that existed before that made it more challenging. But going back to the whole panel, if there was a piece of advice that you could offer to a medical center, to the administrators as they're thinking about the future in regard to treating non-COVID patients in light of a COVID pandemic, if we could have a redo and think about what could be done better that we might be able to take forward with us, what would that be?
So, the reality is that the pediatric cancer community has always been handled with extreme care and caution by clinical care providers, by nursing staff. There's always been this heightened concern for this patient population in terms of trying to remain safe. Obviously, COVID-19 has created an even more heightened concern for families and caregivers, seeing the vulnerability of the population. So, the one bit of advice that I think I would say is just to reiterate, to continue to do what the administration has always been doing, and that is create an environment for pediatric cancer patients that is as safe as possible, and continue to ingrain into parents and caregivers the need to remain vigilant and the need to continue to practice as safely as possible hygiene and traveling to receive treatment and traveling to the emergency department if you need to. There really isn't that much more that can be said about the care that can be given to pediatric cancer patients in terms of trying to protect them from COVID-19. I mean, the evidence thus far has suggested that they're doing fairly well from the perspective of if infected, that the morbidity levels aren't increased dramatically over any other at-risk population. So, I think we take care of our own pretty well.
Lessons to be learned. Chadi, do you want to comment from your perspective?
Yeah, I'm going to take a different take on this in terms of the practical thing. I would say my advice to administrators is to be more transparent and over communicate. I think that us as public, as patients, as families, we react better to honesty and over communication and transparency, even when the news are not the best, versus the sense that sometimes we really are not being told all of the facts. And I think that it depends on the healthcare system, it depends on the hospital, it depends on the center. Sometimes patients just didn't know actually what's going on. And I think it's very important to over communicate in a situation like this. And B, when you don't know what's actually going on, say we don't know. Let's approach this as a community together between the hospital administrators and the physicians and the patient. We realize when things just, when we don't know what's actually happening, but we'd rather have that communicated very well. So I would say transparency and over communication, because you're asking about the administrators. These are the people who wear suits, and Jonathan is wearing a suit today. I'm not, see? So, Jonathan, don't worry, I'm not telling you as your administrator. But the point is, I think, and these are not necessarily the folks who are in direct patient care. They're really overseeing the entire system. And that's where I view that administrative role is very critical, to over communicate, be transparent, and then look at the big picture at all patients, not just the patients that are being with pandemic. There's a lot of other patients that will require care, and have a plan for that. Mental illness, for example, is going to be a big issue after this pandemic. There's a lot of PTSD that we are hearing about among healthcare workers and non-healthcare workers. I'm sure you've seen the stats over the past week about the rise in opioids use and abuse with this. So let's just approach this as a full community, because we're all being impacted. But my advice to the folks who are wearing suits, who are running the hospital centers: transparency and communication.
Thank you. And if we can jump to Corita for her perspective. And Pat, I wanted to come back to you and expand the question a little bit. But Corita, what are your thoughts in the front lines?
Oh, about my own experience, or? About
what advice you'd like to give to administrators in, if you had a chance to do this over.
Sadly, I am a suit. I am an administrator. So. Yeah, it's kind of scary. I think the most important lesson learned here was, we were all working 16 hours a day, 18 hours a day. And I think that was necessary to be nimble. Like, we had a leadership call in the morning. We would all go our separate ways and, make changes, get things done, and then meet again at 6, 7 o'clock. And it was exhausting, but I think that was the only way we could be really nimble and make decisions in real time, because we were literally converting, whole floors of the hospital into ICUs. We were making real-time decisions. I was trying to run meetings and then see a few patients in our virtual urgent care from home, and then go back. And I think it's just that agility, having people quickly be able to move from, seeing patients face-to-face to the telehealth. I think that was a real win, I think, for everyone during this time. Like, I think a few people mentioned that those with many patient advocacy groups have been pushing for this for a long time, and then boom, it just happened, like with the signature, with the single signature. So I think those kind of things, just being ready and being nimble, I think that's the most important thing as an administrator that we need to do. And the PTSD, is really heartbreaking. In New York, we had, I'm sure many of you know, we had an emergency department administrator commit suicide. Lorna Breen, it was all over the news, and that we had to do some real deep reflection after that. Many of us knew her. She's a colleague and a mentor and friend to many, and had gotten COVID, really just felt like she couldn't there was just, she just felt at a loss. Like patients were just coming in, they were dying, and she didn't feel she could make an impact. And who knows if it was partially, you know, the disease that killed her, but her family has done a lot of advocacy and really want her to be counted as a casualty of COVID, because she just changed completely. And she really was a casualty of COVID. And I think the mental health impact on patients, providers, children, I mean, just all of us, it's hard to even begin to get our, to wrap our heads around that. I think we've done some small scale things in our group, like done a screen, send a mental health screen to all of our providers and about PTSD and try to get people services. But, you know, there's definitely more to be done. And I don't even, I'm not no expert in mental health, but I think the ramifications, we can't even begin to understand it yet. And among, you know, paramedics, EMTs, all of us, it's hard to even process it, because I think we're still also in the midst of it and some time needs to pass. And we're just, I don't know, in New York, I feel like we're in that time of like just understanding what happened even, and haven't really processed everything fully.
Before we leave Karina, I just want to follow up and ask. So as an administrator in New York, I feel like there was an idea floated with regard to emergency department patients, screening them before they even came into the hospital. And then if they were positive, sending them to one facility that only treated COVID positive patients. Because my internet connection is unstable.
Yeah,
if you can hear me or not.
No, I heard you.
But does that make sense as a way going forward? Or?
Well, I think that was the idea, was that we were going to cohort patients. I think the whole problem was, it turned out that I can't remember the name of the big ship that we had docked outside Manhattan, but the issue was they wouldn't take anyone. So they had such strict criteria for admission that every patient, like the only patients they would take were the ones we would have sent home anyway, who would have done fine without being in a hospital. So I think that was the idea. And, you know, they opened and then they didn't want any COVID patients. So it was just a very difficult time, and it's hard to even understand all the lessons learned yet. But I think, yeah, that was an idea, but then it just, everyone was so overwhelmed that it just didn't play out, because they couldn't staff up these other places quickly enough.
Yes, in our area, we had a hospital that we routed all the potential COVID cases to, and it worked pretty well. So it was different in different areas, but certainly a learning point. And I wanted to kind of double down on you, Pat, on this question about what to do better, not just reflecting on how to treat non-COVID patients in the case of a pandemic, but also thinking about patients with Duchenne muscular dystrophy are dependent in a great deal to developments from the biopharmaceutical industry, right? We're looking for new trials or looking for new opportunities. You talked about that earlier, maybe aging out of qualifying to some clinical trials. So can you provide advice for both the administrators of the treatment centers, but also to the leaders in an industry that is looking to perhaps reopen and might be very concerned about the level of caution that it needs to put in place to move forward?
Yeah, so I think this is a really difficult question about how do we do this. We work with the pharmaceutical and biotech companies that are in our space, and we have a drug development roundtable in which we get them all together. We talk about things in the pre-competitive arena. But I do think what happens, at least in the rare disease space, is that we don't have the advantage of a children's a COG. That Children's Oncology Group certainly is a model that we all look to and wish for. But what happens is pharmaceutical companies, in a sense, are building a house and then they take it back down again after each clinical trial. So the pandemic makes all of these individual houses fragile. They make all of these clinical visits so frequent, and institutions doing 3 and 4 trials make it impossible to even comprehend what to do next, what trial, how do you prioritize. I really feel like, and we've been working on a platform study design trial for rare disease, for Duchenne muscular dystrophy, but maybe for all diseases if the model works. And I think how to do trials better, how to assess those trials and their protocols, and how to be more inclusive on the protocols. Because if the protocol is just 4 to 8 year olds or people who are ambulatory and can do a 6-minute walk test with 400 meters, it excludes so many patients that I think that we lose our lives and our function waiting all the time, and these families feel like they're outside the bus. So I think if nothing else, we have to think about how can the pharmaceutical companies work together to execute on these trials in a systematic way that gets to a yes or no more quickly, lessens the burden on these patients, and creates the opportunity for more remote learning with outcome measures. I just think we have to change the system, Claudia, because at this moment, the trials are, many of them paused, people aging out, functioning out, can't go to clinics. In addition to the fact that we've talked, and Chatty mentioned about institutions and the various differences in terms of their approach. So we have institutions that have changed their clinical staff and rerouted them to another area of the hospital based on the pandemic. So the clinical teams are falling apart. So it feels like the system that has been set up as sort of independent as each clinical trial was, is now being dismantled. So I think we have the opportunity to change how we do things and create a system that is more inclusive and that is more enabling to patients. And I will come back and make one comment about, I live in Ohio, and I can say that, in terms of the institutions, we see different policies, different hospital administrators saying different things, and that uncertainty has really increased the fear in these patients. In Ohio, Governor DeWine came on TV, once a week on the same day at 2 o'clock. They used to call it Wine with DeWine, but it was a little early for that. But I think what I'm saying here is, in a consistent way, Cuomo did the same thing. Here's what we know, here's what we don't know. If we could get these hospital administrators to get together and say, do that in a consistent way, I feel like consistency and over communication is what we need to do here. And I admire the work of Cuomo, and there's all sorts of politics around it, I'm sure, but at least knowing that at 2 o'clock on a Tuesday, you're going to hear from him, DeWine, and he's going to tell you what he knows and what he doesn't know and what you should be doing. And so I think we can learn lessons from that, and lessons about clinical trials in rare disease populations. Sorry to go on and on.
Fantastic.
So thank you to Pat for that response, and thank you to all of our panelists. And at this point, we'd like to open for Q&A. And I noticed that we've had a number of questions come in, and our panelists have been busy answering them in real time in the Q&A chat function. So I encourage you now to send new questions, and Claudia and I will work through the answered question, the answered questions, and see if there's anything else that needs to be brought to the panel for a live answer on air. But in the meantime, as questions are coming in, I have one more question, and this one's particularly for Chatty. So yesterday on Twitter, which I know you're a big fan of, and so am I, a patient who, I'm not going to say her name because I didn't ask permission, but she posted, recently traveled to another cancer center 6 hours away to hopefully enroll in a cancer trial, in a clinical trial. Due to COVID, staying in a hotel was out. We had to rent a house big enough for our family of 5 since we had no one to leave kids with, and was just talking about the financial and opportunity cost of participating in a trial. And I think we've heard a lot about today about, trials have these costs on participants and families that they shouldn't. The trials benefit all of us. We should make sure that we don't, limit the pool of people who can apply for them. But I'm thinking about the impact on families, the impact of, the patient's family, and not even in the clinical trial situation, just in trying to be treated and trying to make sure your loved ones have appropriate care. And I know you had an experience recently, so I was just wondering if you could highlight that for us and any lessons that we should take for it.
Yeah, so thank you, Allison. So the two experiences, one of them in terms of the clinical trials, actually, since you invited me, I'll have one shameless plug, only one shameless plug, because we actually did write a paper that is coming out on August 6th in one of the journals, and I'll share it with you and the panelists and the listeners about clinical trials and the impact of COVID on clinical trials, because really the silver lining of all of this, if we can really modify things in a way that really makes sense for clinical trial participants, there is no reason why some of the visits cannot be done virtually for clinical trial participants. There is no reason why a patient participating in clinical trial needs to drive for 6 hours so they can get maybe a routine blood test or an imaging study that could be done locally where they live, and the images could be transmitted to the site where the clinical trial is being done. So I think, and the regulatory agencies, actually, the FDA has been pretty generous in modifying some of the requirements for the sponsors and for pharmaceutical companies to allow certain quote unquote deviations, as long as these are just not really major ones. So I think we need to step back and realize, okay, for clinical trials, maybe by doing these changes, we can improve accrual, we can increase the number of participants, which will hopefully translate into patients being served better and advancing science more. The personal experience I've had actually was with my dad. And I also chronicled this, and it's going to be published, I think, in the next couple of days. I think it's in press in a journal, and I titled the article, "The Virtual Visit." And I think a lot of listeners maybe, and the panelists might relate to this, because suddenly, with all of the changes, we had to make decisions as healthcare professionals and what is an essential visit and non-essential visit. And from a patient perspective, when you talk to a patient, every visit to a physician was always essential. And my dad is amongst those patients who always wanted to go and see his cardiologist and visit with him, and he likes interacting with the staff. It was an essential thing, especially as he gets older. This was really something for him, a social interaction for him. And it doesn't matter what the doctor said, it was a good visit because he just wanted to see his doctor. And when I told him that we can't, and we gotta log in and do like a computer thing and a FaceTime and all of these things, like what is that? I mean, how can a cardiologist really help me? How can he put a stethoscope on my chest and heart? It didn't resonate. And you know, we had a lot of technical challenges, which you may smile when you read the article that I wrote. But the take-home message of this is I realized the nice thing about telehealth and virtual visits, and I think there's a place to it. But let's just not, you know, run towards this and imagine that everything needs to be done this way. Suddenly, everybody is just talking about telehealth and virtual visits as if really they are the best invention in the world. And I really worry about this for various reasons, and mainly from a patient perspective. Seeing the physician face-to-face and being able to go there is critical. If you can't, and you have no means to go for transportation, you have physical ailments that preclude you from going there, that's where really it fits in, and absolutely we need that technology. But not everybody has a Wi-Fi. That's for Disparity's question earlier. Not everybody has a computer and a smartphone that they can actually log on. So we just have to be a little bit careful into generalizing a lot of these things that we have generalized. But these were really my comments. My experience with my dad during the virtual visit totally heightened the fact that this is really not here to stay, and a lot of patients are not really comfortable with it. But from a clinical trial perspective, I fully endorse many of the changes that are happening. And I think you're going to see significant improvement in numbers of patients being enrolled that will hopefully help patients and their families.
Fantastic. We've had a number of questions come in through the Q&A function, and I'm very impressed by the panelists' ability to simultaneously talk and answer questions. Wonderfully done. We have a couple of additional questions. I'll kick it off because Allison's internet is acting up a little bit. It was about thoughts on vaccine development, and thinking about specifically the patients that are represented, the patient groups that are represented in our panel. How can chronically ill patients be considered adequately in terms of research trials for vaccines? and receiving vaccines once they are appropriately developed? Is that a concern at all?
I'll say maybe a couple of comments on cancer patients. As you would imagine, in the vaccine development, in the trials are ongoing, likely many patients who have chronic illnesses are being excluded from these trials, the way the vaccines are developed. And then you will need to look at the CDC guidelines after the vaccines are approved and extrapolate and realize that we need to deliver this vaccine. I mean, a vaccine like this, if it becomes available, will probably be given to all, should be given to all patients, given the pandemic. And by default, this means other patients with chronic illnesses. Could there be some concerns about any side effects from the vaccine because it has not been studied in every single patient population? The answer is yes, but I don't think you can answer that. You probably have to do some of the post type of trial or post-marketing studies and try to do some cohorts and make sure that it is actually safe. But it's like in anything in medicine, Claudia, it's risk versus benefits. We don't have always a sophisticated randomized controlled trial to every single thing we do in medicine. In fact, most of the way we provide care for patients is not based on clinical trial data. So in any decision, you balance risks and benefits. And if you believe that the risk of this pandemic is higher than a potential adverse effect for a chronically ill patient that gets the vaccine, then you proceed with caution and hope for the best.
That's good. Jonathan, do you have a different view in terms of how patients who are immunocompromised, who certainly may have issues with vaccines, might look at a potential vaccine for COVID?
No, it's all about striking a balance and looking at the risks associated with what could potentially happen if pediatric cancer patients are infected with COVID. There was always concern, from my personal perspective with my daughter with respect to vaccinations when she was undergoing her treatment. She always received vaccinations, but I always had the fear in the back of my mind about an adverse interaction or some type of adverse immune response. Thankfully, nothing ever came to pass with that. But with that said, again, we have to have this balance here in terms of how this patient population, at-risk patient populations, are treated with respect to undergoing vaccinations and vaccination studies. And it's difficult. Not being a medical clinician, it's, on the one hand, you want, if there is a vaccine or there are vaccine trials that show promise, you want to make sure that as many people are vaccinated as possible. I just don't necessarily know how to bridge the gap between some of the fears that arise in patient populations like the pediatric cancer population in this realm. It's tough. I really don't know what the right answer is in this case. That doesn't answer anything that you asked me, though.
No, but it's something that we're all trying to figure out together. Pat, do you have any thoughts from Duchesne's perspective?
So most, probably 80% of the people that have this diagnosis are on corticosteroids. And typically they certainly do get the flu vaccine, and it really depends on what that vaccine looks like, right? Whether it's an attenuated virus, what are they giving in terms of, I know Pfizer's doing mRNA as well as Gilead. There's a group over in London that are looking at delivery through a nanovirus. So that poses a problem. So that, again, this poses some problem in our community about if you're in line for a genetic therapy using the adenovirus and you get a vaccination that is based in delivery vehicle of an adenovirus, what does that do to your eligibility? So I think, we really have, our community is very concerned about, first of all, they do want vaccines. They do get vaccines. They are very cautious and work in the midst of those corticosteroid regimens that are on, but they are concerned about this particular vaccine and how it's delivered and what that means to their overall health. So I think it's not a simple question.
And Corita, did you want to add anything else before I hand it back to Allison?
Yeah, I just say, you know, depends on the vaccine, right? So live vaccine, totally different story. There's lots of different vaccines, and we just need a lot more information.
Right.
Understood. Allison.
The one thing I would say, the one thing I would say that just to be cognizant of, I mean, there are two issues when it comes to vaccines. I mean, we all know that there's a fraction of the population in the U.S. that doesn't always believe in vaccines. It doesn't really matter. And I think that, in my opinion, that's problematic because that does affect the chronically ill patients, whether they are pediatric, cancer, adults. And, you know, I don't have the latest statistics, but I believe there's probably 20% people within the U.S. who don't really, hopefully it's less, but that's the number I sometimes get quoted, that don't really get vaccines. So if you have a vaccine that's available and it's actually effective and it actually works, imagine you have that and you still have that percent of patient population who don't take that vaccine and they might get ill or sick with COVID, and then it's very infective and contagious. So my concern is, maybe I shouldn't worry about it yet until we get the vaccine and it's effective, but you know, you have to worry about the fact that, you know, even if a vaccine is there will be a fraction of people who will absolutely refuse to take the vaccine, and they will pose risk to the chronically ill patients.
Yeah, for sure.
Yep.
Absolutely. Thank you.
Question and answer section. If you sent a question and we're able to match it with an email address, we're happy to follow up with you by email to try to answer your question if we didn't get to it here. I wanted to do a speed round so everyone gets just like one sentence answer here to try to pull two things together. I saw two questions that came through. One was about, you know, to what extent are we doing things to empower families to feel that they can care for their patients at home? And what are we doing in terms of actually bringing care to the patients? Someone asked, you know, are there visiting medical services, you know, visiting doctors, house calls, et cetera, that we can provide to patients? So I'll respond to that one, and then I'll just go very briefly through the panel to see if you have a one-sentence answer to either of these questions about making families feel more comfortable caring for their loved one at home when they're ill, or bringing care to that person. But what I was going to say is, with regard to clinical trials, I'm seeing an increasing number of trials where instead of saying you have to have an outpatient visit, a visiting nurse goes to the patient's home. So if if all you're doing is coming in for a blood draw or something, there's no reason why someone can't come to your home and do that. I'll start with Pat. Pat, do you have a one-sentence answer to this speed round?
So we are having visiting nurses come in, or PTs coming in. The real worry about these families is, where have they been prior to this, and what precautions do they need to take? So indeed, we do see this happening in our community, and the parents really appreciate it, again, with consistency and the precautions that they need to take. I will just say, and I know this is one sentence, we have an approved therapy that's an IV infusion on a weekly basis, and some of these parents have done that infusion themselves outside on a porch, or ask a visiting nurse to come in, again, outside on a porch with precautions.
Awesome, thank you. Corita? You're muted, Corita.
No, I don't really have anything to say other than thanks for inviting me, and this has been really interesting, and especially having patient representatives, and it's always a wonderful opportunity when we get to interact with patients who use the system and their family members and caregivers and advocates. I think this has been really, really nice to hear from you directly. So thank you. That's all I'll say.
Jonathan, speed round. Any response to those questions?
I'll try and keep it as quick as possible here. Parents in the pediatric cancer community become clinical oncologists. They become clinical neuro-oncologists, looking for every little you know, thing that they can see in their child. And so, you know, the education curve is very fast. I think we do a very good job within this community of trying to empower families and empower patients. And I think now more than ever, given what's going on, they're doing that. This isn't one sentence, but I do want to just say that doing this webinar, you know, in memoriam for Richard Plotkin has been a joy and an honor. He loved your group. He loved working with you. He loved working with Arthur Kaplan, and this was one of his greatest joys, was being involved in this. And no doubt he would have appreciated being involved in this panel, and we would have likely gone well over the 2-hour limit. But that was the joy of Richard. So thank you.
Patty, one sentence answer.
Yes, really, thank you, Allison. Thank you everyone for allowing me to be part of this panel. It's really an honor. I have never met Richard, but I could tell how a great man he was. So I really appreciate the invite and being part of you. I think the one sentence answer to this, I hope a lot of people are trying, a lot of healthcare system are trying to empower families and patients, but we have room to grow. We have a lot of room to improve on things. And we need just to stick together, and hopefully we will emerge on the other side of this stronger and more aligned with the proper values. Thank you.
Thank you to all of our panelists for being engaged in this really interesting conversation. And thank you, of course, Pat, for reminding us of Richard and his spirit and his personality and his work and how important it was to so many people. And Jonathan stole my thunder. I was going to say, I hope Richard would have smiled upon this event. So thank you for joining with us.
Oh, I'll steal the thunder. He is smiling. The sun just came out at the beach.
Excellent.
I'm lucky. That's wonderful. Thank you for including me.
We only have a few minutes left, so I'm going to dispense with all other pleasantries and formalities and say I am turning things over right now to Tara Sklar, who is my esteemed colleague, and I'm going to let her introduce herself at the interest of time. Tara, the floor is yours.
Sure, great. Hope everyone can hear me okay. Pleasure to be with you. My colleague, Christina Kelso, who's been in the background here, is also going to share some slides that I hope are coming up. In the meantime, I'll just explain who I am. Great, thanks. So I oversee our health law and policy program at Arizona Law. I also just, before I say anything else, I thought this was a very special webinar. I do not take for granted to receive accurate and timely information in such a politically polarizing environment right now. So the multiple perspectives that you've brought about patients, rare diseases, support for families and loved ones, it could not have been more touching, and also recognition of Richard's great work in this area. I just thought it was a very special webinar, and I'm so happy that we're doing this with CUPPA. We're doing a few things with CUPPA in addition to supporting a webinar series. And the first is that Allison and her co-instructor, Dr. Tamar Schiff, are leading, is a course going on right now called Access to Investigational Products, Clinical Trials, Expanded Access, and Right to Try. This is a course we hope to offer every year in the summer, in July and August, and we think it would be of interest to many of you regarding the pre-approval space as well as access to care. This course fits within a larger certificate framework. We offer several courses. Basically, they each run between 6 and 7 weeks throughout the year with groups called the Critical Path Institute, who was a nonprofit created in partnership with the Food and Drug Administration, specifically designed around how to accelerate medical product development. We work with them on a number of courses, along with a new group to a new member of our group, the International Society for Cardiovascular Translational Research, and they are mainly focused on medical devices and translational pathways to their approval. So it's a very diverse curriculum within the regulatory science field. And the last thing we do is we have an ongoing speaker series in the fall and the spring, not unlike this type of webinar, where we have what we call hot topics and emerging issues. And that could be something that we could share with this group and others that you could call in or join us for a single talk or the entire course, or ways just to really get more of that desperately needed accurate information now and then looking ahead during COVID and eventually beyond. Next slide, please. Great. So as I was saying, you could, we have lots of options here with our coursework. We have a course that Allison and her colleague Tamara are doing right now, the actual certificate program, and then all these could build towards an actual master's degree in health law, which would consist of those certificate courses I briefly described, as well as additional courses, 5 courses that is basically what a first-year law student takes. How to think and write and research like a lawyer, things like contracts, legal research and writing would be part of the full master's degree in conjunction with those other regulatory science courses. Lastly, we do a number of events. We love these events with CUPA, these virtual webinars. I'm actually based in DC, and we do a number of events in Arizona. So once we can meet in person again, it will be so nice to do that and bring our community together. Next slide. So similar to many of the issues you've talked about, bringing a patient's voice to the surface, a student's voice is far more meaningful than mine. So it's a particularly touching student in that she had no reason whatsoever to actually do this coursework. She only wanted to do it because she wanted to be a better doctor and researcher for her patients. She's currently an MD, PhD student at the University of Arizona. But in general, I'm in awe of all of our students. Most are mid-career professionals, and then a few extremely ambitious graduate students. And it makes for an extremely diverse and well-meaning cohort. Next slide, please. So if any of this sounds appealing, we are taking applications right now for the fall. Our fall starts in mid to late August. Applications are due at the beginning of August. We've tried to make it as simple as possible. It's free to apply. There's no graduate exams required. We are offering a number of scholarships in collaboration with CUPA that we could give more information about if interested. And I'll just wrap up here. So next slide, Christina. So we will be sending out a survey at the end of this webinar, and you can check a box if you'd like more information about this program. Also, at any time, you can feel free to follow us on Twitter or email us, and we'll continue to support CUPA in any way that we can and have more of these really wonderful webinars. So thank you for your time, and thank you to our co-moderators panel and to Mary Plotkin for joining us.
Thank you.
Thank you, everyone, and have a wonderful rest of the day, and thank you for your spending time with us.
So much. Take care.
Thank you.